Am I audible, sir?
Yeah,
Yeah.
very.
Okay.
We are live. We are live.
Okay.
So welcome everyone to this webinar today. And this is on public demand that it has been taken, especially the topic, because this was the demand of our managing committee members as well as our members from the All India Ophthalmological Society. To do a webinar on refractive errors, retinoscopy, and in relation to how to, a topic which is not very well dealt with nowadays, and that is basically on refraction. So I requested Dr. Krishna Prasad R, who also is a very close friend of mine, and from RP Center itself. We work together, and he is currently the director of MM Joshi Eye Institute, Karnataka. And he, along with Dr. Sheetal Savur, who's the head of the Department of Ophthalmology, Yenupoya Medical College, Mangalore, Karnataka. They are going to be doing this webinar, which is on refractive errors, retinoscopy, and acceptance. And this is actually going to be done in 4 modules, and I think Dr. Krishna Prasad will tell you in detail, and it is like a complete course. So over to you, Dr. KP, as we call it, Dr. Krishna Prasad. Over to you. Dr. KP, you'll have to unmute. You have to unmute yourself.
Yeah.
Yeah.
Dr. Sheetal probably can.
Yeah.
Just.
Good evening, everyone. Good evening, Namrata ma'am and Krishna Prasad sir. As ma'am said, sir is the director at MM Joshi Eye Hospital, and he's also a highly regarded ophthalmologist and an academic guru. So anyone who's ever been scared of refraction will learn to fall in love with it once they hear his class, and this is your great opportunity to do so. So, sir was also recently awarded the Dronacharya Award so aptly at the recent AIOSSC International Conference. And with this little introduction and without much ado, I would like to hand over the stage to KP sir. So the stage is all yours.
Thank you, Dr. Namrata. Thank you, Dr. Sheetal. Can you see my slide?
Yes.
Yes, it's visible. If you can
Okay.
put it on, yeah.
Yeah. Am I audible
Slideshow.
also?
Yes, sir, clearly.
Okay. So thanks AIOSSC, Dr. Namrata, for the opportunity. I think refraction, any number of times it is repeated, still it calls for more because it's so important to pass the PG exams. I think all residents and postgraduates taking the PG exam definitely will know this because the examiners know this too well. And any mistake in refraction can be held against you. It is not, people can't be merciful because it is so important for future practice. Any subspecialty in ophthalmology is linked directly or indirectly to refraction. You may have retina, you may go to retina to away from refraction, but if you probably put silicone oil, you will change the refraction. If you put a scleral buckle, you will change the refraction. And your CSCR will cause hyperopia. There are so many things. Any part, like if you're doing cataract or a refractive surgery directly, you have to deal with refraction day in and day out. At the same time, refractive error forms the biggest chunk of the patients coming to us. The visual morbidity caused by refraction, be it refractive errors for distance or presbyopia, which is one of the major visual hurdle which universally affects all. And today, the near vision problem is not taken easy by the patient. Earlier, it was only the problem of the literate people, but now everybody, because of the screens that they use, because of the cell phone usage, the presbyopia or problems with near vision cannot be tolerated at all. So practice is full of things that you do with refraction, and they expect the ophthalmologist to be very adept in the refractive practices. And any mistake in prescribing glasses can turn out to be a real, problem. And at the same time, you have to make a mark. There are many people who know refraction well can rise above the rest and can make a mark. So refraction can be decoded very easily. So today, starting from today, there are 4 modules that we have totally. Today is the first one. Me and Dr. Sheetal will be able to solve all the puzzles of refraction, both for practitioners and residents alike. So let us get to start. Initially, you have to understand vision is not visual acuity. Most of us, like when the residents face somebody who has come for a pre-employment checkup, they want a certificate. Testing about telling about their vision. It is not visual acuity. If you just say 6, 6, and 6, that doesn't end there. There are 5 components of vision. Whenever you give a certificate regarding anybody's vision, always mention these 5 components. Visual acuity is what you measure by Snellen's chart. Snellen's chart is one of the oldest method by which we check the central visual acuity, that to a high contrast visual acuity. Okay, so Snellen's chart was probably picked up 140 years ago. It's a 100% chart, contrast chart. It's a black and white chart. So people will be able to read this chart, but they will not be able to do other things in real life. So visual acuity is a poor indicator of the overall vision, but it's one of the main indicators and indicates macular function specifically. Okay, somebody may have an advanced glaucoma with a 5-degree tubular vision, and his vision may be 6/6. So just telling him 6/6 and assuming him to be normal can be a mistake. So visual acuity is one component which you can normally state as the near as well as the far vision and the intermediate vision. So next is the field of vision. So how much the patient can see, how much the person can see from each eye and binocularly. So field of vision, many diseases of the retina and optic now can cause field of vision problems. So you need to mention, if not by perimetry, at least you need to mention by finger confrontation, is the visual fields by finger confrontation okay? So that is something minimum that you can do for a patient. Don't assume their visual fields to be normal. Contrast sensitivity requires a special chart. Nowadays, with all the charts that we have, the eye charts, we do have contrast chart incorporated in the Snellen's chart. But earlier we used to use a Pellier-Robson chart, which is a very costly equipment to maintain. And contrast sensitivity is a very fine indicator of the not the quantity, the quality of vision. See, patient may be 6/6 on a Snellen's acuity, but patient says he can't see well. That could be because of a small PCO or a fold in the posterior capsule or a fine nebular opacity in the center of the cornea, where his contrast can drop drastically. Patients who have early cataract changes can still read 6/6 parts on Snellen's chart, but they do show their decreased visual acuity on contrast charts. So make it a habit to use contrast chart in your practice so that you can really understand why the patient is unhappy, or you can also make the patient understand that early cataract changes are also important. It is not the Snellen's acuity. So contrast sensitivity is another important aspect which can be affected in many optic nerve and macular conditions, and we need to incorporate this in our routine practice. Color vision, of course, is well known. Ishihara charts are fine. D15 or Farnsworth Munsell 100 hue test, anything can be whatever is available. Even Ishihara chart is fine. So color blindness is quite prevalent, and it has to be a part of an occupation, screening, because in some of the professions we need to really have this color vision tested. And stereopsis. So I'm a strabismologist too. So I cannot really, we cannot really, overemphasize on this. Stereopsis is a binocular function. What about depth perception? Depth perception is a word in English which says the person can probably discern the depth. A depth perception can be even monoocular. When you have a depth perception that is obtained by use of both the eyes, then it is called as stereopsis. So stereopsis can be tested by Titmus fly test, or it can be Randot or TNGO chart. So stereopsis is another part, a quality of vision, where it is so important because any small ocular imbalance in childhood, or maybe a small angle squint, which can be probably missed by the most people. There can be a microtropia. So all these, or anisomyopia, or anisometropia, all these result in lack of stereopsis or a decrease in the stereopsis. Stereopsis can be one single test, which can be probably used by the school screening, where it tells you so many things. It tells you about ocular balance, it tells you about the refractive errors or anisometropia. So we have to use stereopsis. And also, I also want to emphasize that a lot of patients undergo one eye cataract surgery and the other eye they delay. There's an advanced cataract in the other eye. So they almost are monocular. They're using only one eye. They are not understanding that they have lost the depth perception due to binocularity. So lack of stereopsis in the elderly can result in their problems in navigation. They can actually have problems taking stairs and things like that. So they can actually result in falls and fractures. So let us emphasize on the binocular function of stereopsis so that we can reclaim the patient right for a better vision with both eyes, which says that we can detect the problems of both eyes just with a simple test of stereopsis in the schools. You don't have to really check anything. At the same time, the adults and the seniors can, an idea about the lack of depth perception can be a troublesome thing, which may make them to understand the need for the second eye cataract surgery soon enough. So let us start with the topic of today, the errors of refraction. So refractive errors or error of refraction. Basically, eye is a refractive structure which is basically designed for the light rays to get focused onto the photosensitive layer of the retina, which basically converts into signals, sending it to the brain or visual cortex. So eye basically is a peripheral unit of the central nervous system, wherein the photosensitive layer has to receive the images from the outside world and the eye does it. So whatever the errors that happen in the transmission of light from the exterior to the photosensitive layer of retina, they're all termed as errors of refraction. So refractive errors form the, as I told you, major cause of visual morbidity in today's world. And understanding that is very important. So myopia, there has never been another stage than today to understand myopia as a major health hazard. Myopia is become an epidemic. It is increasing, and we have a lot of children today now developing developmental myopia, and we are going to have this as a major health hazard in the coming years. So understanding myopia is important. What is myopia? So myopia is the most common refractive error that we see in clinical practice when patient comes for glasses. They say, I can't see far. Anything they can't see far, patient usually complains, a child or an adult. So what is it? What does really go wrong in that? Is when parallel light rays from outside, when they enter the eye, from infinity, basically they're parallel light rays, they're focused in front of the retina when the accommodation is at rest. This last sentence is very important. This suffix is important because whenever an eye accommodates, the eye automatically becomes myopic. When we accommodate, we add in convex power, we add myopic power. So eye becomes myopic whenever we accommodate. So when the accommodation has to be relaxed so that when the light rays come, they are focused in front of the retina. Why does that happen? Because the amount of convexity or the amount of convex power, the amount of focusing power is too more than what is necessary. That means, let us say, if the emmetropic power of that particular eye is plus 65 diopters, if a patient has 2 diopters of myopia, it is 67 diopters. So it is 2 diopters more than what is necessary. So the light rays will focus in front of the retina. So once they focus in front of the retina in the vitreous, when they diverge, what is actually falling on the retina is a diffuse image of what is actually being transferred. So the patient will get a blur because the light rays are not focused sharply on the photosensitive layer. There's already a diverging light rays that come onto the retina. So this makes myopia a terrible problem. Patients are, when they actually focus, let us say when the patient sees a blurred image, the first reaction by the person is to try to squeeze in the eyes, try to accommodate and see, can you see better? If you accommodate, the myopia worsens. So that is the problem. The patient is completely helpless in myopia because whatever he can do is only to accommodate. But if he accommodates, there is actually a worsening of the myopia. The blood is increasing. So patients of myopia do not use accommodation at all. Their accommodation is rested, or I could say it could be rusted. It is completely in an inactive stage. So children with myopia have very poor accommodative effort because they don't have to use accommodation even for near. That is the problem. An uncorrected myope, a child, hardly uses the accommodation for near because that is the actual usage. So many of these children, because they don't use accommodation, the accommodative convergence doesn't kick in. So most of the children with myopia actually have convergence insufficiency. So this is another problem that brings in, because our eyes are designed in such a way that whenever we accommodate for near, our eyes have to converge, because the brain thinks when we are accommodating, we are looking at something near, closer to the eye. So accordingly, the visual axis has to converge to have a binocular vision. But if you don't accommodate, even the basic convergence also does not happen. So both the accommodative mechanism and the convergence mechanism are not totally underutilized. So convergence insufficiency is a big problem, which leads to exodeviations in myopia. So basically, just having an excess convex power can completely disrupt the normal viewing mechanism the nature has given us. So parallel light rays focus in front, so we have more convex power. That means you need to use a concave lens to basically put those focus onto the retina. You need to reduce the overall convex power of the eye by adding a concave lens in front of the eye, or a concave contact lens, something like that, so that you basically put the focusing right onto the retina, which results in the emmetropic situation. Similarly, hyperopia is the other aspect. I told you, in clinical conditions, myopia is common in your clinics. You will be prescribing more concave lenses than convex lenses. But hyperopia, actually, in incidence, it is the most common refractive error to happen, to occur. But they don't come to the clinic. Let us say there are 15% myopes, all of them will come to your clinic. But in children, there are, let's say, 25% are hyperopes, but they don't come to your clinic. Why? Let us see why. So hyperopia is that error of refraction in which the parallel light rays coming from infinity are focused behind the retina when the accommodation is at rest. Here, what it means, the convex power of the eye is deficient. I told you, if 65 diopters is your emmetropic situation, maybe this patient has only 63 diopters of converging mechanism. That means 2 diopters less. So whatever the light which is supposed to focus on the photosensitive layer is going behind. So the light which is actually falling on the retina is a converging light. It's a converging light beam which is still blurred. So the patient has a blur when it falls on the retina. If it actually allowed to go back, it will probably focus behind the retina. So hyperopia is a condition in which there is a reduced, converging power, or the convex power of the eye is deficient or less. Here, the accommodation has to be at rest, because when we accommodate, I told you, we add in plus power, the eye becomes myope. So then you can probably figure out that in case of hyperopia, we have a way out to solve this problem. When the patient accommodates, automatically you can reduce the amount of hyperopia, or you can even correct it. I told you the eye becomes myope when they accommodate. So every hyperope has an opportunity to correct their refractive error by just accommodating, which is a nature provided mechanism. So patients who have hyperopia, they focus, they actually accommodate, They correct their hyperopia, their vision becomes clear, then they're fine. So they don't come to you in the OPD asking for glasses. So hyperopes are more common in occurrence, but in clinical conditions, people coming for glasses will be myopes. So this accommodation usage to correct is not a normal situation. I want to, warn all the residents that this misuse of accommodation, which is actually, see, accommodation is meant for usage for near. In a normal person, when you look something for near, let's say you're reading something, let's say from the newspaper or a book, you have to focus at, let's say, 33 or 40 centimeters. Your eye has to accommodate, put in the extra convex power to focus at 40 centimeters. So accommodation is for near. But in this hypermetropia situation, the person is using the accommodation for distance or far vision. He can't see the Snellen's chart. That is, he has two diopters of hypermetropia. He accommodates two diopters, the vision becomes clear. Here it's a clear misuse of accommodation. If you misuse the accommodation for distance vision, then you get into trouble. If you use it for near, there's no problem. But it gives an opportunity for the person to correct their hypermetropia without having to use their glasses. So this is the whole situation. So when this balance is broken, when you have way too much of hypermetropia or you have too less of accommodation at your disposal, then this imbalance can create problems. In a child, you have lot of amplitude of accommodation. The child can definitely use some accommodation for distance also and still be happy for near. Whereas as you grow old, you lose that accommodative amplitude, then you have to share it between distance and near, then you get into trouble. At the same time, a child with a very high hypermetropia probably cannot use all the accommodation for distance. It is again falling short for near. So you have many set of problems in hypermetropia in which you have this particular condition. So hypermetropia, which can be corrected by using accommodation, can be called as facultative hypermetropia. That means the faculty of accommodation that actually solves the problem of hypermetropia, corrects the hypermetropia. That hypermetropia is called as facultative hypermetropia. That means facultative hypermetropia is that component which you are correcting by your accommodation. Whatever that remains even after fully accommodating, that is called as absolute hypermetropia. So absolute hypermetropia is that you fully accommodate, try to correct your hypermetropia, but still you're falling short. There is still some hypermetropia uncorrected. That is called absolute hypermetropia. But in children, our accommodation is so much abundant that most of it will be facultative hypermetropia. But as you grow old, some facultative hypermetropia can start becoming absolute hypermetropia. You have no answer for absolute hypermetropia than giving refractive correction. Okay, so this is something you need to understand. And a combination of both facultative plus absolute is called as manifest hypermetropia, which can be corrected with glasses, and which are basically the patient is actually using it in the real life. But there is an element of ciliary body tone. Normally, whenever the ciliary body, see, whenever you accommodate, the ciliary body contracts on our command. But there is a normal tone of ciliary body. The ciliary muscle has a normal tone. That itself is correcting some hypermetropia in most of us. So that normal tone of ciliary body, which is correcting the hypermetropia to a small extent, around one diopter, that is called as latent hypermetropia. Latent hypermetropia is of no use for practical world because it is normal tone. Unless you put a patient on cycloplegia, your latent hypermetropia will not come to the fore. So when the patient is not under cycloplegia, latent hypermetropia need not be corrected. It's only the manifest hypermetropia that we are worried. So next comes the astigmatism. I think it's very easy to understand myopia and hypermetropia, but astigmatism is something difficult. What is the definition of astigmatism? is when the parallel light rays from infinity are focused as two lines instead of a single point. Normally, when the light rays focus, they form a single point. In emmetropia, that point is on the retina. In myopia, it is in front. In hypermetropia, it is behind. But astigmatism is one where there is a difference in the curvature of the two meridia in the refractive surfaces, either the cornea or the lens. Eye is a dual lens system. We have two lenses in our eye. One is the cornea, other is the lens, the crystalline lens. Or in case of a pseudophakia, it is the pseudophakic lens. So we have two lenses in the eye, and the curvature of the two lenses, if the two meridia are not the same, that means if the cornea is not a part of a ball where at all meridia the curvature is same, okay, then the light rays focusing, you will have a one steep axis and one flat axis on this cornea. If it is not a part of the sphere, then you will have the light rays which are going through one meridia, the steeper meridia. They will focus before as a single line, and the light which is passing through the flatter meridian will focus as a line perpendicular to the first line, well behind that. So there will be two lines at perpendicular to each other, separated by a distance. So the patient is absolutely confused. At least in myopia, hypermetropia, they can make some sense. But in astigmatism, whatever you do, the whole vision is a very messy, because there are two lines. Instead of having, there's a default, there is basically a distortion along the two meridia. So the patient visual acuity or the visual morbidity is much more in case of astigmatism. So a small amount of astigmatism is okay, but a larger degree of astigmatism causes a great amount of visual discomfort. So you need to understand astigmatism in different context. We call it as with the rule, against the rule. What is this with the rule? If the vertical meridian is steeper than the horizontal meridian, normally in nature, the horizontal and the vertical meridian are the principal meridia. If the vertical meridian is steeper than the horizontal meridian, we call it as with the rule. Normally, we measure the corneal power in terms of either the millimeters, in terms of radius of curvature, or in terms of dioptric power, which is more user friendly. So we normally ascribe dioptric power to the corneal curvature. If the vertical meridian is 44 diopters, and if the horizontal meridian is 42 diopters, that means the vertical meridian is higher power, it is more curved, it is steeper. Higher the dioptric power, steeper is the curvature, and if that is the vertical meridian, we call it as with the rule astigmatism. So with the rule astigmatism is common in children, and these patients, the line passing through the vertical meridian will focus first and later the horizontal meridian. Against the rule is exactly the opposite. The horizontal meridian is steeper than the vertical meridian, in which the horizontal may be 44 diopters and the vertical is 42 diopters. Normally, aged patients in old age, they develop against the rule astigmatism. That means there is a transition in a patient's life from childhood to old age. With the rule becomes against the rule. So when we operate cataracts, most of the patients in the cataract age group have against the rule astigmatism, where their horizontal meridian is steeper than the vertical meridian. So this is important because most of this astigmatism comes from the cornea. You can also have lenticular astigmatism. You have situation where the lens is having a difference in the curvature. We expect the lens to have uniform curvature, but in case of, let us say, in case of some situations where the lens is having higher curvature in one meridian than the other, then even our crystalline lens can produce a curvature. So when you see a spectacle correction the amount of cylinder in the spectacle correction will be a combination of both corneal and lenticular astigmatism. Whereas when you check the keratometry, it is basically the corneal astigmatism. So if you have a difference between the spectacle cylinder and the keratometry cylinder, please assume that the patient has a lenticular astigmatism also. Even our pseudophakia, when you put an intraocular lens, if the lens tilts in a particular direction, whether it tilts forward or backward, when the lens tilts, it can produce a cylindrical power. So, any malposition of the crystalline or the pseudophakic lens can result in a lenticular astigmatism. So, with the rule, against the rule, is the basic construct that we need to understand. And we have regular and irregular. What is that? If you can probably solve the astigmatism with your spectacles, if it can be resolved into two principal meridia and give glasses accordingly. See, whenever we give glasses, we can actually correct the spherical power and the cylindrical power with glasses. That means we need to understand or basically discern there are two meridia. It may, whatever may be the two principal meridia, if it can be resolved into two principal meridia and can be corrected with glasses, it is called regular astigmatism. Majority of our patients have regular astigmatism. Whereas any corneal pathology like a corneal scar, any corneal injury, any kind of surgery can result in a situation where the astigmatism that is there cannot be resolved into two principal meridia, because whatever cylinders you give, you cannot correct it. It is because of the change in the collagen structure and also the scar tissue, then it results in an irregular astigmatism. Irregular astigmatisms cannot be solved with spectacles. In fact, it's a major chunk of visual problems in case of corneal trauma. So a lot of people with adherent leukomas or corneal scars, even keratoconus, okay, all these patients have a very poor vision because you cannot do an autorefractometry. If you do a retinoscopy, you will never get those, Myers. You never get the reflexes properly. There'll be a scissor reflex. At the same time, whatever lenses you put, they won't accept it. But they have basically good visual potential. So if you can correct the irregularity, you cannot correct with glasses. The best thing to correct is to actually use a scleral contact lens. A scleral contact lens is one which will negate the irregular nature of the cornea. What is a scleral contact lens? It's a hard contact lens which has got a very large diameter. You put in BSS or saline and you put it onto the eye. That means you have the RGP contact lens surface, you have the fluid in between, and you have the cornea. The whole thing becomes one unit, the contact lens, the fluid, and the cornea. So the fluid which is covering the front of the cornea, which is having a irregular surface, will be negated, and there will be a summation of the refractive indices, so that this will completely negate the irregular nature of the astigmatism, and the patient can get very good vision. So the use of scleral contact lens or rigid contact lenses in case of irregular astigmatism has been highly underutilized in today's practice. I urge all the junior residents or the postgraduates who want to really understand this, that whenever you can't really say any patient of corneal trauma, corneal injury has, you can't explain the guarded visual prognosis because nothing can correct it. A simple rigid contact lenses or a scleral contact lenses can correct a great deal of irregular astigmatism. So regular astigmatism is with glasses and regular contact lenses, like soft contact lenses may be toric, but irregular astigmatism would require something, a special contacts like a scleral contact lens. So the next is simple, compound, and mixed. It is for our regular refractive practice. So we can divide the astigmatism into simple, compound, and mixed. So what is a simple astigmatism? Simple astigmatism is one where there are two meridia, I told you. So there's a two lines, focal lines are there instead of a focal point. So two focal lines are separated by a distance. One focal line falls on the retina the other focal line is either in front or behind. But in myopia, it is in front. So a simple astigmatism is one focal line is always on the retina, the other focal is elsewhere. If it is in front, then it is called a simple myopic astigmatism. The example is any cylinder with a negative cylinder at any axis is a simple myopic astigmatism. That means one meridian is emmetropic, the other meridian is ametropic or myopic. Okay, so the correction would be a simple cylinder, a negative cylinder, or a myopic cylinder at any axis. If similarly, if one meridian falls on the retina and other is behind, then it is a plus cylinder at any axis would be a simple hyperopic astigmatism. What is a compound myopic astigmatism? In which both the meridia are myopic. Both the focal lines are falling in front of the retina. Like you have a spherical power which is myopic, you also have a cylindrical power which is myopic. Like -2 sphere and a -1 cylinder at 90 would be a compound myopic astigmatism. Similarly, compound hyperopic is both are plus. Here you have to imagine both the meridia, both the focal lines are behind the retina. At the same time, what is this? You have uh, a +3 and a -2. When you have both, is it a mixed astigmatism? No. For mixed astigmatism, the cylinder has to be more than the sphere. So what is a mixed astigmatism? One meridian is in front, one focal line is in front of the retina, one focal line is behind the retina. Okay, for that, the cylinder has to be higher than the sphere. If you take this, if the cylinder, this is less than this, if you transpose this, this will become a compound hyperopic astigmatism. So always remember the cylinder value has to be higher than the sphere to call it as a mixed astigmatism. So for mixed astigmatism, remember this, always look at the cylinder. If the cylinder is less than the sphere, then you have to transpose it. It will be a compound compound astigmatism, not a mixed astigmatism. And what is very important is when we do a refraction, when we do a retinoscopy. So retinoscopy and acceptance is the second part of the talk today. So whenever you are given an eye and you want to know what is the refractive status of the eye, whether the eye is emmetrope, myope, or hyperope, how do you know that? So how do you know this? You put in light into the eye. You basically throw a beam of light into the eye. The light passes through the cornea lens and hits the retina. And from the retina, it gets reflected back outside. So the light which is coming from the retina passing through the refractive parts of the eye, that is seen by the observer. So you just have to observe what is, it's as if somebody has put a light, switched on a light on the retina. You are actually putting the light in, but in effect, it is basically a light coming from the retina, going through the refraction of the refractive surfaces and coming out to you, and you are receiving it, sitting in front, and you just see, is it going parallelly to infinity? Is it converging or is it diverging? Simple. So to make them, if the patient has emmetropia, then parallel light rays focus on the retina. If you put a light on the retina, when the light comes out, it will be parallel. It will go to infinity. You will never be able to get a focal point. On no point of the screen, you will get a focus because the light coming out from the eye of an emmetropic person will be parallel and it is going to infinity. So we have to make these light rays to converge at some point. So the light coming from the eye has to converge. Then only we can actually get a focus on the screen or see its behavior. So for that, we want to make the eye myopic by 1 diopter. So when you make the eye myopic by 1 diopter, the light rays coming from the eye will focus at 1 meter. So at 1 meter, if you see, and you can actually know whether it is focused or not by moving the light source and there is no movement of the light source, then you confirm that the eye is myopic by 1 diopter. So the entire idea of retinoscopy is to put in the lenses in the trial frame to make the effective power of the eye as a myopia of one diopter. Whether it's a myope or a hyperope, you basically create a myopia of one diopter so that you get a neutralization at 1 meter. If the light is converging at 1 meter, then there is a with movement. If the light is diverging at 1 meter, then you get against movement. So that is how you decide whether you need to put plus power or minus power. So basically, if you just do a retinoscopy at 1 meter of an emmetropic patient, okay, so basically this will always cause with movement. So when you put plus 1, make the patient by myopic by 1 diopter, then you will have a neutralization at 1 meter. So that means the neutralization happens because you are putting by 1 diopter to an emmetropic person, you have made them myopic by 1 diopter. So similarly, whenever there is a with movement, you put plus. Whenever there's an against movement, you put minus, and you wait for the neutralization. Whenever you get that final reading, both vertical and horizontal, what is the power of the lenses that you have put in the trial frame to get this neutralization at 1 meter is our retinoscopy findings. Okay, it is always like a cross. You put values like plus or minus as a retinoscopy finding. And this working distance is very important. I am simplifying this calculations or discussion by taking it as 1 meter. But 1 meter is sometimes too uncomfortable or inconvenient for us to really change the lenses. So we need to sit closer to the patient. So we have actually reduced the working distance to 2/3 meter or 66 centimeters. So when you use 66 centimeters instead of 1 meter, you have to make the patient myopic by 1.5 diopters. Okay, that is the whole idea. So basically, to understand, you keep as 1 meter and subtract, okay, 1 diopter. But for practical purposes, you use 2/3 of a meter and subtract 1.5 diopters. So working distance has to be told for every retinoscopy. For all residents, a word of caution, whenever they give a retinoscopy value, please first confirm the working distance, because how much what you do with those values will depend upon the working distance and also on cycloplegia. If you are not used any cycloplegia, homatropine or cyclopentolate or whatever atropine, because cycloplegia will create a paralysis of accommodation and that will put in some hypermetropia into the scene. So if the patient is having a dry refraction, then it's different. So you need to factor in the cycloplegia effect also, because when you put cycloplegia, the hypermetropia gets added. The latent hypermetropia gets added to the system, which is around 1 diopter in adults, around 1.5 diopters in children. So cycloplegia should also be inquired. So this is the usual starting point of this whole ordeal. You have a cross that you have a vertical, let's say plus 2 diopters, and the horizontal is plus 3 diopters. So that means you have put plus lenses. Let us say you put plus 1, there was a width movement. You put plus 2, the width movement stopped in the vertical direction, but the width movement continued in the horizontal direction. When you put plus 3, then the width movement stopped in the horizontal direction. That means the vertical meridian neutralized with plus 2, the horizontal meridian neutralized with plus 3. Then you need to ask the working distance and the cycloplegia. So the working distance in this, let us say, is 2/3 meter, and it's a dry refraction. So what you do with this? So how do we solve, right, the acceptance of the patient? So when you give a retinoscopy, it is an objective finding. The patient is not doing anything. Patient is not reading a chart. Patient is not answering you. You put in light into the eye and you put lenses and you kept on checking for neutralization and you got the value. This could be the situation in children where they don't cooperate for charts, for patients who are mentally challenged, or patients who cannot actually understand anything. So this could be the only thing, the objective refraction. Okay, so this is the objective refraction. And if you have to give glasses from the objective refraction, we call that as the acceptance. So, what is the final spectacle power the patient wears with this objective refraction finding? We call it as acceptance. This is what the patient is supposed to accept. But in routine cases, we don't give that as the prescription. We have to confirm that by the patient's responses. We have to put those lenses on the trial frame, whatever we are planning to give as spectacle, and check whether the patient really sees well with that, whether is that the really the spectacle correction, which is called as a subjective verification or subjective refraction, which is the point of discussion for the next webinar on 29th, a fortnight from now. So now this is the objective refraction. So if you were to give glasses with only this, what will you do? So for all residents who are the novices in refraction, what you do is a working distance for 2/3 meter, you have to subtract 1.5 diopters. For working distance of 1 meter, you have to subtract 1 diopter. Let us say if it is 2 meters working distance, you have to subtract half diopter, which is very, very impractical. So you have to subtract only from one meridian. Subtract this working distance from one meridian only. For example, it is +2, subtract 1.5 from +2, so plus 0.5. Whatever comes by subtracting from one meridian will be your spherical power. That means the spherical power of this will be plus 0.5 diopters. Okay, then that's all. The sphere is over. Now comes to the cylinder. The two values are different. If the two values are different, there is a cylinder. If the two values are same, there is no cylinder. It's only a spherical power. If both were to be +2, our glasses would have been plus 0.5 diopter sphere. Now there's a difference. So the difference should be written as the cylinder. Don't subtract the working distance from the second meridian. The working distance is over now. Now look for the difference from +2 to +3 and put that as the cylinder. Because once you are given a sphere, it is working in all directions, 360 degrees. The difference should be put only in one meridian. So from +2 to +3, the difference is +1. So it will be a +1 cylinder. For it to work horizontally, our notation will be perpendicular, that will be 90 degrees. So the cylinder value of this will be +1 at 90 degrees. That means it will be plus 0.5 diopter sphere plus 1 diopter cylinder at 90 degrees. This will be the acceptance of this particular patient. So go back again. So you have +2, subtract 1.5 plus 0.5. The difference is +1. Put that as the cylinder at 90 degrees. Okay. So now you say the difference, why it should be +1, why it can be -1 also. So for that, I ask the residents to remember the number line in their mathematics classes in their school. You have a number line, the 0 is in the center, +1, +2, +3 on this side, -1, -2, -3 on this side. So you have to go on the number line, positive side and negative side. So to go from +2 to +3, you have to go on the positive side of the number line by 1 unit. So it is basically +1 cylinder. So the next example. So and at the same time, what is this cylinder? Both are plus. So it is a compound hyperopic astigmatism. At the same time, is it a with the rule or against the rule? So what is the mnemonic to understand this? Minus cylinder at 180 plus cylinder at 90 will be with the rule. You have to probably by heart this. You can actually conjure this up also, but best is to by heart. Minus cylinder at 180 plus cylinder at 90. Both are with the rule astigmatism. So this is plus cylinder at 90. So this is with the rule astigmatism. Let us go to the next example. So minus cylinder at 180 with the rule. Plus cylinder at 180 is against the rule. So now another thing. Now it is +2 vertical, minus 3 horizontal. So what do we do now? Ask for working distance and dry diffraction. So it's 1 meter. So if it is 1 meter, you have to subtract 1 diopter. So it's very easy. Pick up plus 2, subtract 1. So plus 1 will be the spherical value. Now the cylinder is, you have to move from plus 2 to minus 3 on the number line. So plus 2 on this side. To go to minus 3, you have to go 5 units towards the negative side. That means the cylinder will be minus 5 at 90 degrees. So it will be plus 1 diopter sphere, minus 5 cylinder at 90 degrees. Okay. So what is this? Is it with the rule or against the rule? Is it a simple compound mixed? It is a mixed astigmatism because both the signs are different and the cylinder value is more than the sphere, and minus cylinder at 90. I told you minus at 180 is with the rule. So minus cylinder at 90 is against the rule astigmatism. So it's against the rule, mixed astigmatism. So let's take one more. Minus 2 at vertical meridian and minus 3 at, so 2/3 meter and homatropine. Please understand, for cyclopentolate, for tropicamide and homatropine, subtract half diopter more than along with the working distance. Whereas for atropine, subtract 1 diopter. If it is a dry diffraction, don't subtract. So 2/3 meter is, you have to subtract 1.5. Homatropine, you have to subtract again half diopter. So you have to subtract in total minus 2 or 2 diopters basically from minus 2. So minus 2, minus 2. The sphere becomes minus 4. To go from minus 2 to minus 3, you have to go one unit on the negative side. So cylinder will be minus 1 at 90 degrees. So you get minus 4 sphere, minus 1 cylinder at 90 degrees. Again, it is compound myopic astigmatism. Minus cylinder at 90 is against the rule astigmatism. Now look at this. It's a dry diffraction 2/3 meter. So you subtract 1.5 from plus 2.5, that is plus 1 will be the sphere. To go from plus 2.5 to minus 2.75, you have to go around 5.25 towards the negative side. And 135, you have to take the opposite axis. See, the perpendicular axis to 135 is 45. So you will be at 45. So plus 1 minus 5.25 at 45. This is mixed astigmatism and it is an oblique astigmatism. If you have the vertical and the horizontal meridia as the principal meridia, you call it as with or against. Okay, we normally give around 10 to 15 diopters on either side. Like exactly 19, even 85, 80 is taken as with the rule, something like that. But if it is more than 10 diopters, 10 degrees from the vertical or horizontal, then that is called as an oblique astigmatism, not with or against the rule. So this is an oblique astigmatism, at the same time a mixed astigmatism also. Okay, so now you have this kind of a mixed astigmatism. So there is an element of a calculation in refraction called as transposition of glasses. Mostly in the exams, you are asked to transpose the glasses. There is a common belief that when you have an astigmatism like this, a spirocylinder, you have to always prescribe the cylinder in the negative form. Okay. For example, if you transpose this, how do we transpose? It's very simple. You do an algebraic sum of the sphere and cylinder, that becomes the sphere. Change the sign of the cylinder and make the axis its perpendicular axis. For example, plus 1 and minus 4.2, 5.25 will be plus 4. It will be basically minus 4.25, and make the cylinder plus 5.25 and 45 as 135. So this is the transposed form of this. Okay. So these two basically are one and the same. We are transposing glasses to change the sign of the cylinder, but not to change its effectivity. But why there is a rather a myth that we should prescribe in the negative form? Actually, a lot of people think that the patient tolerate glasses better if it is prescribed in the negative cylinder, which is not true. Because whether you give this prescription or this prescription, the effective glasses or the final output will be the same. It is like 2 plus 2 versus 4. Both are effectively same. But only thing is why this concept has come is when you grind the glasses, because nobody will have a ready-made glass for this kind of a prescription. -1, -2 simple cylinders, you will have a ready-made blocks which they can just cut and fit to the spectacle frame. But a glass like this, you have to take a block or a blank material and try to actually grind this to this particular power. At the grinding machine, okay, you have to key in this particular refractive correction. You can only key in the cylinder form in the negative format only. Most of these machines, you cannot input the refraction in both the cylinder forms. Like, for example, Dr. Namrata, whenever we key in our LASIK information before to the machine, when you want to do a laser refractive correction, so when you key in the information, you have to always it accepts in the negative cylinder. Even if the patient has a positive cylinder. For example, if the patient has a +1 sphere, +1 cylinder 180 degrees, we have to key in as +2 sphere, -1 cylinder at 90 degrees. That is how the machine accepts it. So it is better that you give it in the negative cylinder form so that you can actually, it's easy for the person to key in the information to the grinding machine. Otherwise, both of them mean the same thing. So transposition is not for making the spectacle better tolerated. It is only to avoid transcription errors when you're grinding the glasses. Okay, so transposition is algebraic sum of the sphere and cylinder. Change the sign of the cylinder from plus to minus and minus to plus and change it to the perpendicular axis. So let us take some examples like +2 sphere minus 3.5 cylinder at 127 degrees. So do an algebraic sum +2 minus 3.5. It will be minus 1.5 sphere. The cylinder changes to plus 3.5 cylinder. 127 changes to 37 degrees, the perpendicular axis. So this becomes your transposed form. Believe me, both of them, whatever prescription you give, the final glasses will be same. But it will be easy to input this in the grinding machine. That's all. Okay, you can give positive cylinder also, but you should understand the logic. At the same time, there's a problem trying to find the perpendicular axis. 90, 180 we can make out. 45, 135 we can make out. What if it is an odd number? What is the perpendicular axis? We may find some time. For example, here the sphere will be plus 2.5, the algebraic sum, minus 3.75. 63 becomes 153. So how do we know the perpendicular axis? Very simple. If it is a double digit number, add the first, it's a triple digit number, add the first two digits. Like 147, add 1 plus 4, it becomes 57. If it is 178, add 1 plus 7, it becomes 88. If it is a single, double digit, break the first number into 1 plus remaining number. Like 5 becomes 1 and 4, 143. 29 becomes 119. So you can just guess 123 becomes 33, 28 becomes 118, 173 becomes 83, 11 becomes 101, 79 becomes 169, 156 becomes 66, 67 becomes 157. So these are how we can find the perpendicular axis. So basically transposition is for ease of making glasses. It is not to make this. So remember that what is over refraction? So this is the last slide I want to actually cover up. What is over refraction is, it is over your spectacles if you are doing refraction. See, normally you put trial lenses and do refraction. Let us say patient is already wearing spectacles. If it's already wearing spectacles, if you just take your retinoscope and do retinoscopy on the glasses, on the contact lens, it is called over refraction. So ideally, when the patient is wearing spectacles and the spectacles are correct, then you get a with the movement. like in an emmetropic patient. You put plus 1.5 on the spectacle and do a refraction or do a retinoscopy at 2/3 meter, you should get neutralization. So you don't have to worry. If somebody comes and wearing glasses, he does not know whether the number has changed or not. You don't have to do a refraction. You don't have to do an AR. You don't have to do an acceptance. You don't have to check the power of the glasses with lensometer. Just put plus 1.5 on his spectacle in contact with the spectacle. Just do a retinoscopy at 2/3 meter. There will be a neutralization. That means his refractive error and the power of the glasses are matching. No, there's no need to change the glasses. The same over refraction we do on contact lenses. For example, when you do trial contact lens trial, let's say a patient has -5 refractive error, we put a trial contact lens of, let's say, whatever is the plus 4.5 or plus 5. And when he's wearing the trial contact lens, we do a refraction. If we accept whatever he accepts, plus or minus, is added to the contact lens power and the final contact lens is prescribed. So over refraction is refracting over the spectacles or contact lenses, not the trial lenses. And the vertex distance, this is extremely important. Where those lenses, okay, are situated from the eye will decide the overall power of the lenses. For example, our spectacles normally are between 12 to 14 millimeters from the tip of the cornea. So that is where your trial frame should sit. If you put a trial frame too much away from the eye and do a refraction and give glasses, and he wears a spectacle in which they are very closer to the eye, the power will change. Okay, so the vertex distance, because you should understand from the spectacle frame to the contact lens to the intraocular lens, there is a shift in the power. For example, phakic glasses. If you are not put an intraocular lens, if you just do a cataract surgery, the average phakic glasses power is plus 10. The same thing if you want to give a contact lens to the patient on the cornea, it will be a plus 13 contact lens. The same if it goes into the eye, in the capsular bag, it will be maybe plus 20 or 22 diopters lens. So the plus 22 diopters inside the eye is same as plus 13 on the cornea, is same as plus 10 on the spectacle power. If you move the spectacle further, even plus 8 should be enough. So the convex power becomes more and more powerful when it goes away from the eye. So that is what it is. So vertex distance is extremely important to differentiate or to even to know the contact lens power in case of spectacle prescriptions to contact lens practice. And finally, why it is 2/3 meter. I told you 1 meter is easy to calculate, but 2/3 meter is practical. At the same time, 2/3 meter, if you probably go away, actually you need to subtract less, your accuracy will increase. More you go towards the eye, the accuracy of your acceptance will come down. The more you go away from the eye, the accuracy is better. But the thing is, if you move too away, you can't change the glasses. So we have better strike a balance between the two as 2/3 meter. And finally, you should know ocular balance and refractive error. All exo deviations, be it intermittent exotropia, exophoria, or IDS, or an exotropia, you have to fully correct myopia. And all ESO deviations, be it esophoria or esotropia, you have to fully correct hypermetropia. So this is what is the most important crux. So just don't give glasses. Also do a cover test. If the patient has esophoria, fully correct hypermetropia and slightly undercorrect myopia. If the patient has exophoria or intermittent divergent squint, fully correct myopia and slightly undercorrect hypermetropia. Okay, so this is what is the crux of the retinoscopy and how it is get converted into acceptance. I think the most important part will follow it in the next webinar where we actually use the information given from the objective thing and how we actually use that on varying different techniques and gadgets to confirm the final prescription power. In most patients, objective refraction has to be followed by subjective verification, which Dr. Sheetal Saboor will be covering it in the next webinar on 29th, again 2 weeks from now. And I will also be there, and Dr. Namrata will also be there to moderate that. So thank you very much for a very patient hearing, and I'll stop sharing. We can probably take one or two questions and finish the webinar.
So I think, KP, this was a marathon on a subject such as refraction, and you made it sound so simple. Even my refraction got revised. And I think one of the best, no, I can't even say one of the best, but the best class in refraction as far as I know. And you would be surprised to know that the audience was so glued, and we never expected such a stupendous response. But you look at the YouTube or the Facebook or whatever, and I'm sure they're all young students who actually want to learn refraction or even optometrists. But we've had a great response, and I'm sure the next 3 classes would also be very good. And I think the best part is that for the entire time of the webinar, only subject was talked about. I mean, there was no extraneous stray talk or anything like that anywhere. And I think we'll keep it like that. And once all the 4 modules are done, we'll run it like a course as well. So I would like to thank you for one agreeing to do this, sparing so much of time, and also doing it so well. I mean, I knew that it is going to be a super masterclass, but today, because I have heard from others, and that is why I requested Dr. Krishna Prasad. But today, I really felt that it was truly a masterclass. Such complex things, you made it seem so simple, and to make things seem simple, it takes a huge amount of effort. So thank you so much, and I'm sure we are going to have the next one from Dr. Sheetal next time. Thank you, Sheetal, again. And I would again like to thank particularly Dr. Mittal. Dr. Mittal was the one managing committee member who said that this is very much needed for our postgraduates, and all of them then in unison said, and I'm happy with it. Thank you, KP. Thank you, Dr. Krishna Prasad. Thank you. Thank you, Shri.
Thank you so much for the opportunity.
No,
We'll catch up on 29 with
no,
more
no.
information.
Completely our pleasure and our
Thank you. Good night.
children are fortunate that they have you. Thank you.
Okay, bye.
Thank you, sir. So, do you want to take one or two questions, sir, or do we end it? Hello?